Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing a very short topic but very important topic clinically known as trigeminal neuralgia. This disease is also known by a lot of other names like tic douloureux, Hunt's neuralgia, and suicide disease. Why is it called as suicide disease? Because patients suffering from this disease complain of this excruciating, unbearable pain in the facial area, and that is why this is known as suicide disease. So, trigeminal neuralgia is actually a chronic facial pain syndrome which is characterized by episodes of sudden onset, intense stabbing electric shock like pain in the area of the face where the branches of the trigeminal nerve are distributed. And this includes the lips, eyes, nose, scalp, forehead, upper and lower jaw. Now, to understand better, we first need to know the trigeminal nerve actually provides sensation to the face through three branches known as the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. And as you can see in the image over here, each of these three nerves supplies different areas of the face. And amongst these three nerves, usually the ophthalmic one, first of all, let's know the ophthalmic one is known as V1, maxillary is known as V2, and mandibular is known as V3 nerve. And amongst these three nerves, trigeminal neuralgia more commonly affects V2 and V3 areas. So this disease is very common. It is seen about in 4 to 5 people per 1 lakh in a year. And usually the disease begins around the age of 5th to 7th decade. It is rarely seen before that, before the age of 30 years, except in multiple sclerosis where it can have an early onset. And if you come to the sex prevalence, females are more commonly affected than males in this disease. Now let's talk about the causes for this disease. The causes can be divided according to the cause. This disease can be divided into three types: classical, secondary, and idiopathic. Now, first, let's talk about classical. Classical cases is seen in 75% of the cases where the cause is usually the compression of the nerve root by an aberrant blood vessel. Secondary cases, which is seen in 15% cases, is when there is an underlying pathology like multiple sclerosis or tumors. And third type is the idiopathic type, which is seen in 10% cases where the cause is unknown. So, amongst all of these causes, the most common one that we are seeing is that the trigeminal nerve can undergo a compression, either the compression of the nerve or the Gasserian ganglion. This Gasserian ganglion is also known as the trigeminal ganglion, and this is located in an area which is known as the Meckel's cave. So we see a compression of the nerve or this ganglion by other central causes like, for example, aberrant blood vessels or an aneurysm or posterior fossa tumors, cholesteatoma, multiple sclerosis, AV malformation, and even post-injury after some kind of trauma. And very important to know that in multiple sclerosis, this disease is much more commonly seen, and this is seen the disease starts at an earlier age than other cases. Other than this, the cause could also be due to aging changes in the nerve or irritation by adjacent aberrant arteries. There can be a chronic myelin loss at the trigeminal root entry causing the aberrant conduction. Now let's discuss how will this patient present to us. First of all, this is a very painful condition. So the patient will come to you with a sharp, lancinating facial pain, which is usually unilateral in nature, but in very rare cases, in about 3% cases, there can be a bilateral pain. And this pain is described as a very sharp or stabbing or electric shock like pain, which is very severe and intense, and it can last for a few seconds or up to 2 minutes. It can occur multiple times a day and more commonly seen in the territory of the maxillary and the mandibular nerve, but very rarely involves the ophthalmic area of distribution as well. And it can occur in periods that last days to months, separated by remissions that lasts months to years. So this is the prime feature that you see in this disease. And the patient will complain to you that they have a lot of triggers that suddenly start the feeling of pain in them. These triggers can be like just a light touch, it can be like washing your face, shaving, brushing, loud noise, or even temperature changes. When the cold air hits your face, the patient can suddenly experience this stabbing electric shock like pain. And trigger zones, when they are lightly touched, they incite such intense pain. And these areas are usually located around the ala of the nose, along the gums, and over the hard palate along the lower lip. There are two very characteristic distribution of pain which is described by patients, one of them being more common than the other one. So the more common one is the pain begins in the lower canine tooth area and then it travels along the lower jaw to just in front of the ear, and sometimes it can round into the upper jaw and involve both the V2 and V3. So it will start somewhere in the lower canine area and go in front of the ear, or it can even take a turn and involve the upper jaw, and this will involve the V2 and V3 distribution of the nerves. And the second, less frequent type of character is it runs from the upper incisor or the canine and it goes up the side or inside the nose and it encircles the eyes, involving both V2 and V1. So this distribution is a little different where it starts in the upper canine and it goes up. It can go up from here or it can go up through the nose and it encircles the eye. And this will involve the distribution of the V1 and the V2 nerves. So there is the very important feature that you have to remember here is that there is a very strict localization of this pain in the fifth nerve territory, and this is what makes it very diagnostic. Anything that is deviating outside of the fifth nerve territory will not be a case of trigeminal neuralgia. And sometimes the patient can also complain of a transient sensory deficit after the spasm of pain that they experience. However, any kind of sensory loss, impaired corneal reflex, or fifth motor weakness should invalidate the diagnosis. There can only be a very transient sensory deficit, no permanent deficit as such. Now, coming to diagnosis, how do we diagnose such cases? This case is mainly a clinical diagnosis. Very rarely we need to do some investigations for these cases only when we are suspecting that there could be an underlying secondary pathology which is causing this. So first let's talk about the diagnostic criteria over here. According to International Classification of Headache Disorder, ICHD-3, we can make this diagnosis when these criteria are hit. First being the pain lasting for a fraction of a second to 2 minutes, severe in intensity, and electric shooting, stabbing, sharp character. And this is precipitated by innocuous stimuli within the affected trigeminal nerve distribution. And the third condition being this is not better explained by another ICHD-3 condition. This will clinch the clinical diagnosis of this case. And in other cases, like we might need to do some investigations, like for example, total count and differential count to follow up the side effects of carbamazepine and phenytoin treatment. Other than that, if we had to find any underlying secondary pathology, like for example, multiple sclerosis or aneurysm or posterior fossa pathology, we may need to do an MRI brain and an MR angiography. So this is about the diagnosis for these cases. Let's see what could be the possible differential diagnosis. It could be due to a dental cause like dental caries. There can be a temporal myositis, any temporomandibular joint disorder, migraines or cluster headache, mandibular osteomyelitis, temporal arteritis, and postherpetic neuralgia. Last of all, let's discuss the treatment. Now, the treatment can be medical and surgical. What is the aim of the medical treatment over here? The aim of this treatment is pain relief for the patient. So first of all, you need to educate the patient and reassure the patient about the condition and the treatment that you would be giving them. And the first line drug that is used here is carbamazepine. The dosage used is 100 to 200 milligram twice daily. This has been seen to provide acute symptomatic relief in about 90% of the cases. Other than this, there are other medical alternatives like other drugs which can also help in pain. These include phenytoin, baclofen, oxcarbazepine, clonazepam, valproic acid, gabapentin, topiramate, and lamotrigine. And ironically, here, any other painkillers that we usually give in other headaches like paracetamol, NSAIDs, or opioids, they are not at all effective over here. So, once we see that the patient is not at all responding to the medical treatment, at that time we have to consider surgical options. Now, what do these surgical options include? The first line is nowadays that is used is microvascular decompression surgery, where we remove the vessel away from the nerve root. And in this surgery, we have seen that about 62 to 89% patients are actually pain-free at 3 to 11 years of their follow-up. This involves very limited complications which may or may not be facial hypoesthesia. So this is the first line of surgery that we perform. Other than this, there are other surgeries like peripheral neurectomy near the foramen rotundum. If you remember, foramen rotundum transmits the V2 nerve, the maxillary nerve. So we can do a peripheral neurectomy over here. We can do a Gasserian ganglion injection. The Gasserian ganglion being located in Meckel's cave. And this can be approached through foramen oval. We can do a root section of nerve, intracranial decompression of trigeminal pathway, intramedullary trigeminal trichotomy, radiofrequency gangliolysis, and stereotactic radiotherapy. Both of these options are very ablative in nature and not used until the last moment. So this completes everything you need to know about trigeminal neuralgia. If you have any other question, please note them down in the comment section, and I'll see you in my next video.